Welcome to the Acupuncture Outsider podcast. My name is Richard Hazel, and in the time it takes for you to commute to or from work, I hope to have shared something of interest about orthopedic acupuncture using motor points, trigger points, myofascial slings, neurofunctional acupuncture, segmental treatments, anything that crosses my mind that seems to be of interest. I hope you'll enjoy it. Hello, and welcome to another episode of the Acupuncture Outsider. This is Richard Hazel, and today we're going to talk about low back pain. Or I'm going to talk about it, and you're going to ignore me. No, I'm kidding. Vladimir Janda said most issues or most problems, talking about musculoskeletal pain and muscle imbalances, most problems start at the pelvis. And I'm going to explain to you how that applies to low back pain, because in my opinion, most low back pain starts at the pelvis. And when you want to work with someone on maintenance, once you have them out of pain, why you're going to continue to return to treating the pelvis, because it's so important. Low back pain, if you have low back pain, you know how I would talk about knee pain is the symptom of a hip imbalance. And we'll go into that. But low back pain is a symptom of a hip imbalance. So if that doesn't make sense to you, please listen. If it does make sense to you and you already know this, you can go back to your crossword. But the pelvis, the main thing to think about in the pelvis is where the upper body meets the lower body at the sacrum. The sacrum takes a lot of pressure from above. It's the bottom of the spinal cord, spinal column, and it meets the pelvis at the SI joint, so that you've got the pelvis. And so force transmission comes straight down and then divides between the two legs, or it comes up one leg at a time and has to be dynamically stabilized at the SI joint. The SI joint can move slightly. It is called nutation. In English, we have a word called nutation. I don't know if there is a similar word in other languages, but it's basically the ability to anteriorly tilt. So nutation. The SI joint there are a lot of ligaments in the pelvis that are very important, but the most important one for what I want to talk to you about is the sacrotuberous ligament. There is a ligament that goes from the lower part of the sacrum down to the ischial tuberosity on each side. So you have this really strong ligamentous stabilization of the sacrum. The sacrum still has the ability to anteriorly tilt slightly to lock itself in the pelvis for better force transmission. When you are lying down, there's no anterior tilt, there's no nutation and locking. When you are sitting, there is no nutation and locking, but when you stand up, there is. As soon as there's some force transmission, the sacrum will nutate and lock in place for better transference of force. And what's going to help stabilize that little joint, that SI joint, will be ligaments and muscles. Or you could say ligaments and tendons and fascia. So you have this ligament that goes from the sacrum to the ischial tuberosity on both sides. The hamstrings and the adductor magnus connect at the ischial tuberosity, and they share some fascial connection to that ligament, the sacrotuberous ligament. So the hamstrings and the adductor magnus can help stabilize the ligament that stabilizes the SI joint. So you can actually say that hamstrings are involved and adductor magnus are involved in SI joint stabilization. The primary stabilizers of the SI joint are the glutes, the gluteals, gluteus maximus and medius in particular. Glute max has a very strong ability to stabilize the SI joint. The deep rotators, the piriformis, the two gemelli, and the obturator internus all help stabilize the SI joint. They all come in toward the sacrum and toward that ligament and have connections that help stabilize the ligament that's stabilizing the SI joint, stabilizing the pelvis, basically. So that's the main stabilizing of the SI joint. Now, you have the erector spinae and to some degree the QL, but the erector spinae in particular have an aponeurosis that covers the sacrum. They come down and cover the sacrum. So that aponeurosis is helping to stabilize the SI joint. So the spinal erectors are also able to help stabilize the SI joint dynamically when there's any kind of movement, pressure, transference of strain or force that goes through the SI joint. So it's this huge intersection, and it's really, really important that it be really strongly stabilized. The body has mechanoreceptors in the fascia that helps it feel, and the SI joint itself has proprioceptors that help it to feel the dynamic shifts of weight so that the body can perfectly stabilize the SI joint. We don't have to think about any of it. It's all programmed in. We've learned, all of this has been learned by the body. It's all done at a subconscious level, mostly the subcortex, but partially also cerebellum. But it's a learned movement pattern that the body has that we do not have to spend a single bit of energy to do. It will happen on its own. Now, what happens when the gluteus maximus becomes inhibited primarily from an anterior pelvic tilt caused by the hip flexors like the psoas, the TFL, the rectus femoris, the sartorius? What happens when that anterior pelvic tilt is creating, well, shutting off the glute max for one, but also putting more strain on the SI joint? So what happens is the deep rotators that are prone to shortening because they have so much slow twitch fibers so that they don't fatigue, they will get tighter. And over time, after they've been tight for a long time, they start to actually shorten. The muscle cells will depolarize and shorten. So you end up with a situation where you have tight deep rotators, inhibited glutes, tight glute medius and inhibited glute medius, and tight hamstrings, and then also the spinal erectors and the QL. QL, I would say, is getting tight when you have back pain more because of that counterbalance against the psoas pulling the spine forward. So, and I've talked about that before, but when the psoas is tight, it increases the lordosis in the low back, and then the QL is protectively tightening to stabilize, to protect the low back. So you get the QL getting tight for that reason, as well as just trying to stabilize the hips. The QL gets tight when the gluteus medius is weak. If the gluteus medius is weak, your body doesn't want to have that Trendelenburg sort of dip on the opposite side, so that the contralateral QL can tighten to pull the pelvis up a bit to help maintain stability. So you have that as well. All of those things begin to cause a lot of tension in the low back muscles and the gluteal muscles. Gluteus medius can cause low back pain because of its attachment at the iliac crest of the pelvis. It creates a deep ache and even sharp pain into the L5 area because the fibers point right in that direction. And when you get some active trigger points, you will feel sharp pain that feels discogenic. And it's really often from the gluteus medius trigger points. And then you have the pain caused by a hypertonic and shortened QL. And then you have pain caused by the hypertonic erector spinae because they're trying to stabilize the SI joint. And so it's just a bad recipe for low back pain. The QL, the psoas can cause a lot of low back pain if it gets short enough. If it's short enough, not only is it putting pressure on the discs in the lumbar area, but it actually just causes a lot of pain around L5 and the SI joint just from that constant pulling forward the tendons, and even I could probably even make an argument that the ligaments can cause inflammation, so that you start to have a lot of pain in the low back from a tight psoas. But that's all pelvic. The psoas does attach to the diaphragm. It does get involved in core stabilization, but it's a huge hip flexor and lumbar flexor. So I would count it as a pelvic muscle. It's connected to the iliacus, which is a hip flexor. So you have the psoas affecting SI joint stabilization. You have the glute max shutting off and being unable to stabilize well. You have that ligament that's supposed to help stabilize the sacrum to the pelvis that can become dysfunctional. You'll notice there are a lot of women, usually in the third trimester, start to have sciatica because of laxity of those ligaments in the pelvis. So then the deep rotators start to get really, really tight just to help stabilize, and they can start to brush up against the sciatic nerve and cause irritation. Something I treat all the time with no electric stim, of course. Put them on their side, treat their gluteals and their piriformis, sometimes deep rotator, put the needles in, let them lie 20 minutes on their side, and they're way better. So I would treat TFL too. Glute med, TFL, glute med, glute med, piriformis. That's my magic recipe for pregnant women with sciatica. So the SI joint, the pelvis, the anterior pelvic tilt, huge part of low back pain. You will find a lot of people with low back pain with tight hamstrings for this reason. Hamstrings are trying to help stabilize the ligament that stabilizes the SI joint. So when you have someone out of pain, their maintenance should include the gluteals, piriformis, occasional release of the psoas, not every single time, but you do need to release it regularly, especially if they're physically active. If there's cyclists or runners, someone who does a lot of hip flexion, repeated hip flexion, their psoas is going to get short faster than somebody who just relaxes or works at a desk or drives or whatever. Sorry if you hear my dog in the background. There's a pigeon on the windowsill. So the maintenance for your average adult should include the glute muscles, the gluteus medius. I don't always treat glute max. I feel like I'm getting it when I get glute med, and if I was staying on top of hip flexors, I'm not that worried that the glute max is going to be inhibited or tight. It's not that prone to shortening. I really focus on muscles that are prone to shortening. So piriformis, glute medius, QL, the longissimus on both sides, in the lumbar area, and occasionally hamstrings if that person is prone to tight hamstrings. They're physically active. Um, Stay on top of things like the TFL and glute min. Stay on top of the rectus femoris and the psoas. That's great maintenance for low back pain. Every once in a while, it's good to get into the obliques, the abdominal obliques, and maybe even rectus abdominis. I'm guilty of not doing a ton of that because, well, it's no fun for the patient. It's a little weird feeling. And also, I find that if you stay on top of the pelvic stuff and the SI joint, their core is strong. So I don't really focus on it a lot, and I know there are a lot of people who are all day long talking about the core. But if my patients are doing well, I don't see any reason that I need to buy into the dogma about the abs having to be treated every time. Um, so the most problems do start at the pelvis. If you stay on top of the pelvic muscles and the SI joint stabilization, you will help a lot of people who have other issues like hip issues. Think of how many hip issues are caused by deep rotators getting tight, or the psoas getting tight, causing impingements in the groin area for hip. Think about how much knee pain is caused by the pelvic stabilizers. That can be adductors, that could be IT band. Think about how much knee pain is caused by tight quads, especially rectus femoris. It's all starting at the pelvis. Psoas gets tight, and now rectus femoris works harder. Now you have knee pain. There are just so many things that start at the pelvis. And if you can stay on top of the SI joint stabilization and good pelvic alignment, not too much anterior pelvic tilt, people do very, very well for many, many things. So that's what Dr. Janda recognized. And I think a lot of people still don't realize how right he was. But hopefully, what I just told you planted some seeds and will help you to think through your maintenance plans for your people when you got them out of pain. Like, what should we really be focusing on to keep them out of pain? And if you have someone who's in pain, hopefully some of the things I've told you about were things that you had not considered and that you can consider, and you start to see how much you can help somebody. One thing you'll see with someone with chronic sciatica is maybe you're working on the rotators, and maybe you're doing some trigger point work on the piriformis or the superior gemellus, and they're still having sciatica come back. Start checking anterior pelvic tilt, because when you can correct the pelvic tilt, those deep rotators don't have to work so hard, and they shouldn't be getting tight again and hitting the sciatic nerve. So think about anterior pelvic tilt, psoas, TFL, rectus femoris primarily, maybe even gluteus minimus. Think about those muscles that can increase pelvic tilt. And sometimes you'll find an iliacus issue that you want to treat straight into the iliacus, as opposed to the common shared tendon below the inguinal ligament. I tend to release the psoas below the inguinal ligament, and I'm getting the psoas and the iliacus shared tendon there. They kind of overlap right there. So I'm getting both with that needle. So I don't tend to go straight into the iliacus that often. But when I need to, I do. And how do you know? Palpation. Palpation every day. Palpation. You can muscle test all day long, and things might fool you. Person might have strength in the synergistic muscles and can trick you. But palpation on an iliacus that's in trouble will tell you everything. It will be much more sore on the injured side, on the short, tight, ischemic side. So palpation all day long. Okay, hopefully that was helpful for somebody. And Yeah, have a great day.